Bismillahirrahmanirrahim. Assalamu alaikum. My name is Muhammad Zahur. My roll number is EP1770103. The topic of my presentation is histoplasmosis, which is a fungal infection. Fungal infections are also called mycosis, which represent the invasion of tissues by one or more species of fungi. They range from superficial localized skin condition to deeper tissue skin infections to serious lung, blood, septicemia or systemic disease. Following are some fungal diseases of human. The first one is histoplasmosis, which is the topic of presentation, which is caused by the Histoplasma capsulatum. Blastoplasmosis, which is caused by Blastomyces dermatitidis. Cryptococcosis, caused by Cryptococcus neoformans. Cutaneous mycosis, Trichophyton species. Pneumocystis pneumonia, which is caused by the Pneumocystis carinii. Candida, which is also called oral thrush, which is caused by the Candida albicans. And the aspergillosis, which is caused by the Aspergillus fumigatus. Now the histoplasmosis. Histoplasmosis is a disease caused by the dimorphic fungus Histoplasma capsulatum. It is present in the tissues in yeast form. It measures 2 to 4 meters in diameter and filamentous mold form in the cultures and in the soil. The perfect form of Histoplasma capsulatum is called Amonacella capsulate or Agelomyces capsulatum. You get infected by breathing the fungal spores. You cannot get the infection from someone else. Histoplasmosis is often mild with no symptoms. If you do not get sick, it usually affects your lungs. Symptoms include feeling ill, fever, chest pains, and dry cough. In severe cases, histoplasmosis spreads to other organs. This is called disseminated disease. It is more common in infants, young children, older adults, and people with immune system problems. These are the causative agents of histoplasmosis. Birds and bee droppings. Infected bees spread the fungus in their droppings, fungal spores, etc. Now the case presentation. A 33-year-old white female presents after admission to the General Medical Surgical Hospital with a chief complaint of shortness of breath on exertion. She reports that she was seen for similar symptoms previously at her primary care physician office 6 months ago. At that time, she was diagnosed with acute bronchitis and treated with bronchodilators, empiric antibiotics, and a short course of oral steroid taper. This management did not improve her symptoms and she has gradually worsened over 6 months. She reports 20-pound intentional weight loss over the past year. She denies camping, spelunking, or hunting activities. She denies any sick contacts. A brief review of symptoms. System is negative for fever, night sweats, palpitations, chest pain, nausea, vomiting, diarrhea, constipation, abdominal pain, neural sensation changes, muscular changes, and increased bruising or bleeding. She admits a cough, shortness of breath, and shortness of breath on exertion. The history of the patient shows that she have hypertension, cholecystectomy, tachypnea. She takes lisinopril, which is ACE inhibitor, 10 mg once daily. No known medicine, food, or environmental allergies. The vitals of the patient are: temperature is 97.8 Fahrenheit, heart rate is 88 per minute, respiratory rate is 22 per minute, blood pressure is 130, 86, body mass index is 28. The initial evaluation of the patient is platelet counts of 74,000 पर मिलीमीटर क्यूब, जो कि बहुत कम है। उसके साथ साथ हेमोग्लोबिन 8.3 ग्राम पर and mild transaminase elevation AST 90 and ALT 112. Blood cultures were drawn and currently negative for the bacterial growth or gram staining. Chest X-ray shows the mild interstitial pneumonitis. Confirmatory evaluation CT chest was performed to further the pulmonary diagnosis. It showed a diffused centrilobular macronodular pattern without focal consolidation. As this was her third day of broad spectrum antibiotics for a bacterial infection and she was not getting better, it was decided to perform diagnostic bronchoscopy of the lungs with a bronchoalveolar lavage to look for any typical or rare infections and to rule out malignancy. Bronchoalveolar lavage returned with a fluid that was cloudy and muddy in appearance. There was no bleeding. Cytology showed Histoplasma capsulatum. The diagnosis, based on bronchoscopic findings, a diagnosis of acute pulmonary histoplasmosis in an immunocompetent patient was made. Diagnosis, based on bronchoscopic findings, a diagnosis of acute pulmonary histoplasmosis in an immunocompetent patient was made. Now the treatment. Pulmonary histoplasmosis is an asymptomatic patient, is self-resolving and requires no treatment. However, once symptoms develop, such as in our above patient, a decision to treat needs to be made. In mild tolerable cases, no treatment other than close monitoring is necessary. However, once symptoms progress to moderate or severe, or if they are prolonged for greater than 4 weeks, treatment with itraconazole is indicated, which is an antifungal drug. The anticipated duration is 6 to 12 weeks total. The response should be monitored. The response should be monitored with the chest X-ray. Furthermore, observation for recurrence is necessary for several years following the diagnosis. If the illness is determined to be severe or does not respond to itraconazole, then we goes towards the amphotericin B should be initiated for a minimum of 2 weeks but up to 1 year. Co-treatment with methylprednisolone is indicated to improve pulmonary compliance and reduce inflammation and thus improving work of respiration. Thank you.